constant?
No.
No, they are, this one is pretty long, and then we don't know how long is that one. This one, and then the QRS, they're pretty regular there, but the P wave is everywhere, right? So we don't really know. So that's why, what we call?
It's a 3rd degree.
3rd degree, a lot of times you can hear it's a complete heart block, right? That means there is no conversation or communication between the atrium and the ventricle. Ventricle just, there are times I got the message and there are times I just don't get the message, right? So that's why it's complete heart block. Do we treat atropine with this?
No.
Okay? If you have this type of patient, what would the first thing would you do? What would you do for this patient? You hook up to the monitor, it shows 3rd degree heart block, what do we do? First thing, you gotta put a patient on baser, okay? Put them on the transcutaneous basis. Okay, good. Questions? Y'all want to take a quick break to go back?
Yes. Patient on baser, right? On the 3rd degree.
Why are you doing that?
Oh, can I pause this? I think I can.
Not to work anymore. So that's what they call, then you won't see any P wave at all. That means your atrium is not pumping. You lose that atrial kick, right? Remember, even though the heart is filling up passively, but the last 1/3 portion of the blood is improved by that atrial kick, that atrium pump, right? So if you're losing that, will you die? No, it's just you don't have enough filling pressures. That's what it is, right? So I just want you guys to know that would be sometimes you lost your P wave, and that's because your atrium is not working. Your atrium, what they call quivering.
Is that AFib?
That's what we call atrial fib, right? That means the atrium is not working. So how can we tell that the patient has atrial fib? First of all, you will not see P wave at all. P wave totally disappeared, right? Second of all, your ventricle, that means your R to R will be irregular, right? You won't see, it will be very irregular. So that's what they call irregular rhythm. We call it atrial fib. That means that the ventricle just pumps whenever they feel like the full, they pump. They feel the full, they pump. But the atrium will not pump at all. It's like quivering. And what's the downside of it? What's wrong with that? So what? You still have filling pressures. Your ventricle is still pumping, but what's the risk?
Poor cardiac output and...
You may have poor cardiac output because you don't have a filling pressure as much, right? And if your atrium is not pumping effectively, usually what's going to happen to the blood?
Blood clots.
Yeah.
You're going to end up, your blood is stagnating, right? It's sitting there. Remember, that was the problem with the blood. If you're stagnating, then you're going to be up with the clots. So that's why the bigger problem would be the clots. Right? So the thing is that, when we're treating atrial fib, if your patient has the new onset atrial fib and you don't recognize it and you waited for 24 hours later, your next nurse coming in and say, oh, doctor, your patient had atrial fib. The first thing, that's what you want to know. When does it start? Well, I don't know. I come on my shift, I see atrial fib. My nurse gives me a report, she says sinus rhythm, but it's not sinus rhythm, atrial fib. The key thing for you to remember is that if it's more than 24 hours, usually we don't cardiovert patient, or we don't, usually we try to slow down the rate, but we're not cardiovert the patient because you're going to send that clot straight to your head.
Give Coumadin.
So a lot of times we end up treating patients with the blood thinner. Okay?
You start with heparin, right?
We start with heparin. If the patient in the hospital, you start with heparin, right? And then, why do we have to start heparin and Coumadin at the same time?
Coumadin takes a while.
Good. Yeah. Coumadin will take a lot longer for work. It usually takes 3 days for it to work. And heparin is short-lived and is faster. So that's why when you put a patient on heparin, what do you have to monitor? The PTT, right? Remember, heparin is PTT. Coumadin is
TTINR.
TTINR, right? Well, actually, you can regulate INR with both of them. Well, let's see. What's the difference between the INR and the PTT? They both measure your blood thinner, but the thing is that the INR is what you can gauge when do you titrate the drug. Usually, if the heparin, the doctor always order to titrate the PTT, but with the Coumadin, we like to regulate with the INR. When is the ideal INR for patients who are on Coumadin?
Oh, geez.
2
2 to 2.5, right?
Okay.
So usually it has to be 2 to 2.5 normal time. So that's why a lot of time the PT is really high, but the thing is the INR is not in the therapeutic range. So usually we use a high INR is to regulate the therapeutic range of the Coumadin, right?
Yeah.
So that's why the patient who is atrial fib, the first thing what we do, if we don't know when is the time started, then we usually start them with the blood thinner. Or if we do know the time, if they say, well, I just noticed that he go into atrial fib right now, what do you think that the ideal treatment for these patients?
Cardioversion.
They cardiovert. Yeah. What does cardiovert mean is that, they try to synchronize the rhythm and put the patient back to the sinus rhythm. So that's what they call cardiovert. But the thing is that, let's say we don't even know what time, what do you think they should do first before they do cardioversion?
Check that blood.
Huh?
Blood test first. Find out what
Not blood test. Well, how do you know that you have clots in your atrium?
Oh, it's
EKG.
echo. No.
Pretty close.
Cardioversion or-
What they call is TEE. Okay? It's a transesophageal echocardiogram. So they do put an echo down into the heart to look to see, make sure that there's no clots in there, right? Before they do the cardioversion. That is something that's very important that they have to do. TEE, transesophageal echocardiogram. So
Are they going to do that once they're in the ICU, or are they going to do that immediately in the ER? Because we've never. I'm just saying that our ER.
well,
we've
if
never
they
done
decide to cardiovert the patient, they have to do a
that.
TEE.
If they don't know, they'll usually start with heparin.
If they don't know, they
just do it,
start with heparin.
and
Yes.
and then they don't, and then they'll try to medicate
Yes.
to
Yes.
cardiovert instead
Yes.
of actually like.
But if you do the electrical, you have to do a TEE. It doesn't matter where they are. But if they decided to do the cardioversion, they should do the TEE. If they don't sue them, but you can get a stroke for that. Okay? So that would be one thing that I would about atrial fib. The biggest problem with atrial fib is patients may end up with a stroke if we don't treat them appropriately and if we don't recognize them, the symptom early enough, right?
Well,
So-
wouldn't it be like a pulmonary?
It may cause pulmonary embolus, but what really is, the problem is that, remember when the ventricle, if the clots go into the ventricle, when it pump, where does it pump to? Straight, huh?
Goes
No.
from the right
No,
atria?
No. When your blood ends up in the left ventricle,
Oh, no.
when it pumps,
It's going to go up into
the aorta is gonna,
Yeah.
25% of your blood gonna go up there.
But isn't the blood clotting in the right atria?
The blood is clotting the right atria, you're right. But the thing is, sometimes it's so small that it's passing
Through
through.
the lung.
It goes pass into the pulmonary artery and the pulmonary veins. It's going through it.
It doesn't cause an emboli, and then it cycles back through the heart and goes.
Exactly.
Your vessels
So
are a lot
it's big
smaller.
enough to get cause pulmonary.
Much more likely to-
Yeah. Well, like I said, I have not heard about atrial fib will get into PE, but it could. I'm not saying it's not going to
But
happen.
it's way more
It
likely to
could.
get a stroke.
Yeah.
Mhm.
Yeah. But most likely it's stroke because of the ventricle pump. The pump is the aorta. The blood goes straight into the head. So that's why. Okay. So that would be atrial fib. No P wave, irregular R to R. Yeah? Now, if sometimes you have irritable atrium, right? So what does that mean when you have irritable atrium? What's going to happen to the atrium?
They'll wig out, but
You
they'll.
pump all the time. Something that tickle the SA node all the time, right? If it tickle. So what you going to see? What are you going to see? they call flutters, right? But what are you going to see on your EKG? A lot of P's. Yes, you see like 2 or 3 P's, a very fast P wave, and then you see a QRS. A lot of P, and then you can see a QRS. So that's what we call atrial flutter. But what do you think the QRS is going to be? The R to R? Going to be regular or irregular?
Irregular.
It's true. Remember, there's
No,
nothing.
it's going to be regular.
It's going to be
Nothing wrong with
regular
that.
because your atrium got tickled. That doesn't mean your ventricle got tickled, right? So you got a lot of P wave, but your R to R will be regular. So that's why they call regular rhythm, right? So no P, we consider what? Atrial fib. And you lose what type? Why do we care about atrial fib? What do you lose? You lose your atrial kick, you lose your feeling pressures, right? And that will cause less, you lose your cardiac output, right? Good. And what's the risk you put a patient at if patient in atrial fib? You don't recognize it on time?
Coagulation.
You end up with hypocoagulation, or you end up with clots, and you end up with a stroke, right? And before you do a cardioverter for the patient who have atrial fib, what do you need to do first?
Transesophageal.
Right? Transesophageal. Okay? So that's what you need to do. And then, if your SA node gets tickled, what do you call that?
The flutter.
What
Atrial
will
flutter.
you see?
A lot of P's.
Lot of P's. What about your R to R?
Regular.
Gonna be regular, right? Yeah, so that's what you call, and that would be atrial fib and atrial flutter, right? Now, the next thing we want to learn is your QRS. Remember, we have to look at the QRS. Is it normal or abnormal? What's the normal QRS?
0.6 to 0, or 0.06 to 0.11.
Okay. 0.06 to 0.11. Remember, the point is very important, okay? So when you do your exam, make sure you look at your decimal. Yes. Anything greater than 3 bucks, we consider abnormal QRS. When the QRS is so wide, we call PVCs. We call premature ventricular, right? Contractions. So that's what we call PVCs. So it's very important, again, when you have PVCs, that we got to think about, okay, why do we worry about PVCs? Again, the problem is that the contractility of the ventricle is not effective. So that's why we worry about PVCs. What's the most common cause of PVCs? No, PVCs got nothing to do with AV nodes now. Now we're talking about ventricle. What caused the heart pump?
Oh,
Electrolytes, right? It's always your potassium is very important. You know, got to look at your electrolyte, look at your potassium, look at your magnesium, because those are the things that will help your heart to depolarize, right? The conduction of the heart. So that's why you got to look at your electrolytes. PVCs is always, most of the time will be your electrolyte. Either too much or too little, okay? So
The torsades, that's specific to the mag sulfate.
magnesium, yes. Yes. I'm not going to torsades because, you know, again, you got in the advanced med surg, you're not in the ACLS, you're not in the critical care component nurses, so I'm not going to even go into torsade. I'm not even going to go into premature junctional rhythm. Those are the things that, you know, you guys not need to know because it's just getting more confusing, okay? So just stay with the basic, how we survive with critical care. That's what I want you guys to do, okay? So that's what I want you to understand. That's what PVCs. PVC, if you have like more than 6 beats of QRS, Y QRS right next to each other, what would they call that?
That's going to be ventricular tachy.
They call that, they call
SVT.
ventricular tachycardia. So they call VTAC. That's what you hear a lot. It's like a V. They call VTAC. Okay, they got to be more than 6 beats. Less than 6 beats, what do they call?
Is it SVT?
They call PVCs. They call PVCs, but they have name for it, you know, couplets and triplets and things like that. But but the thing is that, you know, just stay. If it's more than 6 beats, you call VTAC. If it's less than 6 beats, you should call PVCs, right? Or run PVCs, or you can call it run a VTAC if more than 6 beats. And the things that you should be worried would be your electrolytes. If your electrolytes is normal, then what we're treating with is antidysphosphatic drug. Okay? So there's only one drug that you have to remember nowadays is your amiodarone. Your favorite friendly drug, the amiodarone, is your treatment for any sort of dysrhythmia, especially PVCs or VTAC, after you treat your electrolytes first. Okay? So
Does that stop the heart at all?
it doesn't stop the heart. It just regulates the rhythm for you.
Yeah.
Can you repeat, sorry, can you repeat the drug name?
Amiodarone.
Odorone.
Odarone. AMI.
AMI.
ARON.
NEI.
Okay, so while I'm going down and get my PowerPoint, I want each of you to take a strip and see. I think I have enough strip.
Thank you.
And see if you can make sure you know your rate. Let's see.
Cheat sheet here. Yep.
Make sure you have all those 5 steps before you even talk about your rhythm. Okay?
Okay. I got this. It's upside down.
Okay. So let me go get your PowerPoint.
Where are my glasses?
I might need those too.
We need to work together. Okay. Work smarter, not harder.
Yeah, let me try on my own because I don't want to confuse you. Because I have my own special way of figuring it out.
I was talking to the wind.
Oh, okay.